Well, I think we may as well start actually, if that's,
Okay,
if you're okay,
great.
Chief.
Yeah, that's fine. So I'm just going to hide this video. No, not the. Yeah. Okay. Well, thanks very much, Rachel, for organizing these meetings. I think there are a silver lining to the COVID cloud. It's really good to hear about all the research in the Institute. This is what I'm going to talk about today, is the Alkaptonuria metabolic state, what we need right now, an anti-infective condition. And the alternative title would be Lessons from a Rare Disease. So, oh, it's not moved on. Oh dear. Oh, that's okay. Yeah. So what I'm going to talk about, I hope you can see the mouse there. What is Alkaptonuria? This is the rare disease we work on. How research in Liverpool has led to the first effective treatment for AKU, which is how I'm going to refer to Alkaptonuria from now on. Lessons we've learned from about more common disorders from studying AKU. And finally, some data which has come up very recently and is one of these lessons, and that we think we might have discovered a completely new anti-infective condition. So AKU it has a sort of iconic place in the history of medicine because it was the first human disorder to be recognized as a genetic disease. So if you all are aware of the work of the Austrian monk Gregor Mendel, who published his findings on the genetics of peas in an agricultural journal, and it was fairly widely ignored by mainstream biology and medicine. But this chap, Archibald Garrod, who was a physician in London in the late Victorian period, and of course later, he realized that some human disorders might follow Mendel's laws. And one of the first, in fact, the first one that he showed to follow Mendelian inheritance was Alkaptonuria. So it actually holds a sort of iconic place, and it's regarded as the first of the inherited disorders of metabolism. So what is it? Well, it's characterized by a high urinary excretion of HGA, homogentisic acid, which causes darkened or black urine. It's an autosomal recessive disease, single enzyme deficiency, and it's caused by the failure to break down homogentisic acid, and it's the lack of this enzyme, HGD. So the this pigment, this chemical HGA, is deposited over time as ochronotic pigment, mainly in collagenous tissues, and it leads to a rapid early onset osteoarthropathy, and the incidence is about 1 in 250,000 internationally, but in fact there are some hotspots where the incidence goes up to about 1 in 10,000. So this is the pathway. It's an enzyme in the breakdown or the catabolism of phenylalanine and tyrosine. And basically, this enzyme here is mutated and is basically there's a lack of the enzyme. Some of you might also be aware of another genetic disorder in this pathway, HT1, which is actually a much more serious disorder. So we have this block here. So the homogentisic acid, which is normally very rapidly metabolized, and that's the chemical structure there, circulates, and it's we think that it goes through a step called benzoquinones, and then it's deposited as the pigment. And I'll show you some images of that. But in fact, most of this homogentisic acid is actually excreted in the urine. And here's an example. You can see this is a normal person's urine, and these are 2 AKU patients. And the ones here on the right-hand side are where we've alkalinized the urine, and it turns it the HGA black or dark. This will happen over time, but you can speed it up with alkali. Now, in children, they have the dark urine, but they don't show any other signs. But then over time, we start to get depositions of what we think are HGA polymers in connective tissues. And the most obvious is the sclera, but we can also see it in the cartilage of the ear. See even more there. And unfortunately, a lot of it is deposited in joints, and this is an ochronotic knee joint. Apologies to those of you who might be having a meat sandwich at the moment for lunch, and you can see the cartilage is turned black, and we've actually got loss of cartilage here. So what I want to tell you now is how research in Liverpool has led to the first effective treatment for this disease, which, as I said, is sometimes regarded as the oldest genetic disease. And if we go back to pre-2008, I was actually working on a completely different area. I was working on Purinoceptors in bone and in skin and cartilage and cancer. And in fact, this is one of the early papers we published on the Purinoceptors. This is back in 1995 when we cloned one of the receptors, then called P2U, but it was later changed to P2Y2. And this is the last one we published, which was in 2016. And this is interesting because this is on the P2X7 receptor, and it's a very polymorphic gene. This is the structure of the receptor. And this is nothing to do with what I'm going to say about anti-infective conditions later on. But if I was still working on this, I think this could well be an anti-COVID target, because one of the things that this receptor does is regulate the secretion of cytokines, including IL-1. And I think it might well figure in COVID research later. And I think the polymorphisms in this gene might be related to how seriously people are affected. But anyway, back to AKU. And the reason I got interested in AKU was because of these people here. So Prof. Ranganath, who's now the director of the Alkaptonuria Center, was then a consultant clinician in clinical chemistry. And he was approached by Robert Gregory, who had a terrible disabling osteoarthritis. Rob was a very charismatic person. Sadly, he's passed away now. And he was misdiagnosed for many years and eventually found out that he had Alkaptonuria. He enlisted Ranga to set up the Alkaptonuria, the AKU patients group, AKU Society. As I said, Rob passed away, and we actually found out that he had been diagnosed as a child because of the black urine, but had actually been sent away from Alder Hey many years ago, and because he was told there was nothing could be done about it. And then his parents forgot he had it, and he just came to terms with the fact that his urine was dark. But anyway, when he was diagnosed with AKU, he really wanted to do something to help AKU research and therapy. And so soon afterwards, Nick Siro also came on board. He has 2 children with Alkaptonuria, and he eventually became the chairman of the AKU Society. Now, Ranga came to see me because he knew I had an interesting cartilage, and he asked me if I'd do some work on AKU. We had a first grant was, I think, £4,000 raised by the patients, and I thought, yes, this is an interesting sort of side project in the lab. Of course, over the years, it's become our dominant research theme. So the first research on AKU that was actually done in Liverpool was actually a post-mortem from a body donation, not to HARC, but actually to the Department of Pathology, and it was done by Tim Helliwell. And here you can see the very dark cartilages in the elbow joint. You can see the cartilages in the tracheal ring, so it's not just the skeleton that's affected. But most interestingly on here, you can see the heart valves. And so these are the aortic valves, and these are the pulmonary valves. And you can see there's a big difference in pigmentation. And we think, well, we more than think, we know now that this is because of the high pressure and high flow in the aortic valves see. So this pigmentation is related to loading, and we'll come back and look at that more closely. So the first study we did was actually the development of an in vitro model, and this was done by an Erasmus student, Laura Tinti. This is a picture of Laura last year in Siena, but of course this work was done many years ago when Laura was a young Erasmus student. And so that was the first work we did, and then we recruited Adam Taylor, who was our first PhD student. Adam's now the head of anatomy in Lancaster. And so we developed an in vitro model, but we also started to look at samples from tissue donated from AKU patients who had surgery. And one of our first sort of mini breakthroughs was that you can see here, this is the pigment in unstained sections, but you can see that we can actually amplify this stain by using small stain. And that helped us, for instance, in identifying the pigment in tissue culture. And it also helped us identify, as you'll see later, to identify pigment in the mouse model. So we started to do a lot of work on donated tissue, and we managed to enlist some really super collaborators, and probably the foremost of these is Prof. Alan Boyd, who's now at QMUL. And Alan's an expert in skeletal structure, skeletal imaging techniques. Here you can see the cartilage from an AKU-affected joint. And I initially assumed that, of course, the pigment would come in from the synovial space and that the tissue would pigment from the articular surface. But it doesn't actually. It starts to pigment in the subchondral layer and then spreads. This is one of the first things that Alan found out for us, that actually in this disorder, we can get complete loss of the subchondral plate. This is a scanning electron micrograph, which is an extraordinary phenomenon. He'd never seen this before in any skeletal disorder. And that's just showing that at higher power. So this is some work that Adam Taylor did. This is histologically, and you can see here, this is a joint removed from an AKU patient. In fact, there's no pigmentation here apart from this first pigmentation in the chondrocytes in the calcified cartilage. So this is a pigmented condom. That's pigmentation starting off in a joint. Once it starts off, it proceeds very rapidly. You can see here in another image, this is all pigment unstained, but you can just see the pigment. It's present in different forms, very densely here. There's more there. And in this patient, we've got a peppery pot type distribution. And here you can see this phenomenon again of no subchondral plate. Adam also did some EM with Ian Pryor and the group in the Sherrington building. And one of the things we found is that the first pigmentation actually lines up with the periodicity of collagen. So we realized that tissues are initially resistant to pigmentation, and then through compositional or organizational change, probably associated with aging or degradation, they become susceptible. HGA is deposited in the tissues, it makes the tissue stiff and prone to mechanical damage, and then that is a downward spiral because the mechanical damage leads to more HGA deposited in tissues. And I'm going to now just show some recent data from some mouse experiments that Juliette Hughes did, where she counted the pigmented chondrons in the intervertebral disc. Got a nice intervertebral disc here, and you can see, that the lumbar intervertebral discs have got far more pigmentation than the tail. Of course, the lumbar discs, even in a mouse, are loaded. Now, it's not just compressive loading, because here we've got a very nice image of an Achilles tendon in a mouse. This was done by Craig Keenan, and you can see that the tensile forces here also cause pigmentation. So the pigmentation is certainly related to mechanical loading. Once pigmented, you can see that the actual tissue becomes stiffer. And so this is some non-pigmented cartilage, this is some OA cartilage, and this is some ochronotic cartilage. Big increase in stiffness or in Young's modulus. So we developed this sort of model of joint destruction. I'll go through this quite quickly. So we have here healthy joint, the first deposition of homogentic acid as ochronotic pigment, then we get others. This soon spreads through the joint into the hyaline cartilage, the non-calcified hyaline cartilage. eventually to the articular surface. Now, this stiffness here causes an unloading in the underlying bone, and we get a sort of focal disuse osteoporosis. So the osteoclasts come in and start trabecular thinning, and they also remove the subchondral bone. And eventually we get pigmentation right to the articular surface, and then failure of the joint. Pigmented cartilage flakes off, and some is driven down into the marrow. Now, one of the things that's we notice when the cartilage pigments is there's a loss of glycosaminoglycan. This is again some work that Adam did on a visit to Virginia Krause's lab in North Carolina. And we can see here the GAG content of non-OA joints. OA joints here have got lower GAG content. Of course, AKU are much lower. And we then developed what we call the exposed collagen hypothesis. And basically, this is a collagen fiber with the protective proteoglycans decorated on there. HGA comes along and can't get at the collagen, but through aging or loading, we lose proteoglycans from the collagen. The HGA gets in and then binds to the collagen, makes the collagen stiffer, and then it's a downward spiral, and we get dense pigmentation of the collagen fibers. Okay, now that's all very interesting, but it doesn't really help. It helps us in understand the natural history, but we couldn't actually test any therapies. So we wanted to get a mouse model, and we got a grant from the Big Lottery Fund to do that. The last medical grant they ever gave. After that, they only gave the money to sport. And there was a mouse model of AKU which had been identified in the Pasteur Institute, and this is a wonderful demonstration of it because this is the homozygous mouse here, and you can see it's got black litter because of the urine of the mouse. So you can phenotype these mice very easily. Now, this had been developed through ENU mutagenesis, and so it was a very helpful model, but in fact, much more recently that George Bougarias, his team have developed a new targeted mouse for us, and that's been proven to be really useful in understanding the metabolomics and in fact the disorder itself. But I'm not going to talk very much about that today. And I have to say that was a tremendous feat because George did that on a shoestring basically. So we've now got a targeted conditional model. When we first got this Pasteur mouse, there were reports in the literature that the mice were genetically they had genetically AKU and biochemically AKU, but they didn't show ochronosis. Now we looked carefully. We did all sorts of things to try and find ochronosis and to induce ochronosis in these animals. But in fact, eventually we found that it did exist anyway. And this is a wonderful example of that because here we see an ochronotic knee joint stained with Schmall stain. And this was done by Craig Keenan with a lot of assistance from Hazel Sutherland and Pete Wilson and various others in the team. And you can see that each chondron is stained blue, and so we can count these, and I'm just going to make that a little bit bigger. So it's a wonderful bioassay of ochronosis. And if we plot this over time, sorry, yeah, that's okay. So what we actually could use this for is to try and test therapies, and here we have a potential therapy which we started to investigate. I'll come back to that. But basically, that blocks the tyrosine pathway further up the above homogentic acid, so you don't get homogentic acid formed. So when we took the AKU mice and we measured the circulating homogentic acid, and then when we treated them with this drug nitisinone, which inhibits this enzyme, we saw that the homogentic acid level dropped completely. Now, what about ochronosis? So here we've got the time course of ochronotic pigmentation in AKU mice. So this is mice up to 80 weeks. And this is the number of chondrons counted. I think the red and black are, I can't remember if this is male or female. We also had biopsy and black 6 mice in here. But anyway, you can see this wonderful progression. And we're also interested to see that the pigmentation starts very early. We can actually detect pigmentation in mice in 10 weeks. So the belief is in humans that we don't see a lot of ochronosis until late teens, early 20s. But in fact, we don't. It may be that there is pigment being laid down earlier than that, and we can't see it. The first place we see the pigment is in the tibial, the knee joint, the tibial and femoral cartilages. So this is another. This is the data plan plotted in a different way. And what we did is we treated some mice from birth with nitisinone. And what I have to do now is just show you this little arrow down there. So basically, nitisinone completely blocked ochronosis, which was a remarkable result. No adverse effects on the mice. The mice grew well. Didn't see any other difference, but it completely blocked ochronosis in the mice. And if we let the mice grow for a few weeks and then put them on nitisinone, we arrested the ochronosis. We didn't see any evidence of reversal, although we're now seeing some in humans. But it showed that even if you start nitisinone at any stage of life, basically it arrests ochronosis at that stage. So I hope I've stressed this point that ochronosis is this pigment that's laid down. And as far as we know, in humans, this is the major cause of all of the pathology, this pigmentation. Okay, so we published a few papers on the mouse model, and what this really did was give us hope that we could try this in humans with AKU. The people at NIH had done a trial before that, which had failed. They couldn't show any benefit with nitisinone, but they looked at one variable, which was hip rotation. And the problem is that if you take people with AKU and they've got advanced disease, giving them nitisinone and stopping further pigmentation isn't going to have a big effect on a very damaged joint. So what we did is we got together a consortium, which was led from Liverpool. Ranga was the PI, and it was the clinical development of nitisinone for Alkaptonuria. It was obviously we're very pleased to get this. It was actually the highest rated of the grants. We had a team of patient groups, a pharma, regulatory people. We had 3 clinical sites. Piastany, you won't have heard of probably. That's in Slovakia, which is one of these countries with quite a high incidence. This was awarded in November 2012, and it was for 3 trials: 1 to look at age of onset, 2 to look at dose ranging and effects on circulating HGA, and the biggest one, which was SONIA 2, was to look at the clinical effects. So in fact, this is the list of them here, and we call them SOFIA, SONIA 1 and SONIA 2. And SONIA 2 ended in January of last year. So to do SONIA 2 and SONIA 1, we had to actually develop the assays for HGA, which are here, and that's the team from clinical chemistry: Andy Hughes, Anna Milan, John Davidson. And of course, we also needed a way of measuring the clinical effect. And so Ranga developed this scoring system called the Alkaptonuria Severity Score Index, ACUSI. And this was to get around the problem of just looking at one single variable that might not change sufficiently during the trial period. SONIA 1, as I said, was a phase 2 dose response study. What it showed very clearly is that urinary HGA was lowered very well by these doses. So these are the doses of nitisinone down here, after 2 weeks and 4 weeks. And here we've just missed off the control so that you can actually see the dose response of the different doses, 1, 2, 4, and 8 mg. Now, there was a lot of discussion about which dose we should use in SONIA 2, which was the clinical effect study. And we actually went for high dose, in fact, 10 mg, so that we put down the urinary and circulating HGA as much as possible. So that was SONIA 2, and that was published in the Annals of Rheumatic Disease, nearly 4 years ago now, actually. Okay, so the next study then was the clinical study looking at clinical effect. And what we wanted to do here was measure ochronosis. We couldn't obviously do invasive things like biopsies, so we were relying on scoring of the eyes. And Jane actually undertook this scoring. She was the assessor, blind assessment. And in retrospect, we made things difficult for ourselves because we didn't have enough categories. We had non, slight, and marked. Really, what we should have done is had a lot more categories, because it's very difficult to go from one category to another. But of course, once you start a clinical trial, you can't start playing with the outcomes. But despite that, last year, a little bit later than this, in the year, we had our last Developer Consortium meeting, and the SONIA 2 data had then been analyzed by the statisticians, and we got a decrease in urinary HGA. We knew we would get that. We've obviously seen that clearly in the mice. The American group had seen it as well, but we needed to show the clinical variables were different. And we actually got specific differences in the acousi, which is the cumulative score, eye pigmentation, ear pigmentation, and some other things, osteopenia, and the number of spinal regions with pain. So it looked like a great success, and we are currently, that paper is currently under revision. I've just put Ranga down, who's the chief author. There's a lot of authors on this paper, but the interpretation is that 10 milligrams a day is well tolerated. It reduces excretion of HGA, but it also improves clinical signs indicating a slower disease progression. So I think this is quite a triumph, actually. And the Sobi, the drug company that we collaborated with, we had to drag them into this trial, but they were super collaborators once we got them in there. Based on the phase 3 study, they have submitted a market authorization to the EMA. So hopefully we will see this licensed and approved. Now, in parallel to that, Ranga actually undertook an observational study with the patients attending the National Alkaptonuria Center, because they weren't in the trial. They were already getting nitisinone off license. And in this study as well, although it's not a control study, we showed an effect of nitisinone. So basically, that study worked on following the progression of the disease before they went on nitisinone, and then seeing it flatten off afterwards. On the basis of these studies, nitisinone is now used off-label in UK, France, Spain, Netherlands, Denmark, Sweden, Slovakia, Australia, USA. Some notable exceptions there in countries who aren't keen on off-label use. Some people have actually moved to Liverpool so they can be near the National Alkaptonuria Centre, move from abroad, and they can get the drug. There's an interesting article in Nature about this program of research. It's focused basically on Nick Siro, who's the chairman of the AKU Society, mainly. So it's called The Father's Fight, and it was also mentioned in Dr. Weston's casebook in episode 6. Okay, so what I've done now is I've told you what alkaptonuria is, how research in Liverpool has led to the first effective therapy. Now I want to talk about what lessons we can learn about more common disorders by studying AKU. And the idea really is that in extreme phenotypes of Mendelian disorders, disease progression is rapid, so it's easier to identify initiation and advance of pathological changes. We were particularly interested in doing this because of osteoarthritis, which is a major cause of disability, but has no therapies. In fact, AKU is the first form of osteoarthritis that there is now a therapy for. I think that rare diseases are a neglected area of study in OA. We've certainly had problems getting funding from the osteoarthritis charities. I think this year we've had a bit of a breakthrough because I was actually invited to the main osteoarthritis meeting in Vienna, which should have been last week. Obviously, I couldn't go to give the keynote address on this. So I think people are now listening to us. And Neil Thomas, whose work I'll show later, was also going to give an oral presentation there. So basically, our theory has been that greater focus on rare cartilage syndromes could lead to more rapid advance. Now, this idea is not new, and some of you will recognize this picture. It's William Harvey, a great physician of the 17th century, who's much better known for describing the circulation of blood. But I won't read, in the interest of time, everything that he said here, but you should look at this. And basically, the last sentence is the key one. By careful investigation of cases of the rarer forms of disease. So if you want to find out about medicine and biology, look at rare diseases. This was echoed by William Bateson, who was actually basically the founder of genetics. He was the first person to use that term. It was Bateson who convinced Garrod that Mendel's laws applied to humans, and he said much more succinctly, treasure your exceptions. So what we've learned from Ochronosis, I call it, or from AKU, I call it lessons from Ochronosis. And we've identified some new microanatomical structures and some new pathogenic mechanisms. So the first one, this might be most interesting to the people who are very interested in bone remodeling. I don't know if Rob Van Toft and co are online, but basically we found here some new anatomical structures. These things we call trabecular excrescences. So this is normal trabecular bone, and these things here, which are whiter, that's higher mineral content, are novel structures that we first found in AKU, but actually subsequently found them in cadaveric bone. Here's a scanning EM of them, and you can see that these wonderful, almost like cauliflower-like structures. This, of course, is one of Alan Boyd's EMs. And we thought that these shapes are very interesting, and then we decided that they might have something to do with adipocytes. So these are adipocytes in the bone marrow, and you can see that they template these excrescences. They might actually contribute to the production of these. So it's a bit of a revolution in bone remodeling, this, because basically lining cells, which are thought to be the cells that are in close contact with the bone, are not all of an osteoblastic nature. Some of them are, well, maybe even the majority of them are adipocytes, and in certain situations they can contribute or regulate bone formation. Here's some further examples. And we've not done any further work on this, but Adam Taylor is pursuing this. And there is more and more interest in the role of adipocytes, and certainly in osteoarthritic bone, the amount of adipocytes and the adipocytic templating of bone seems to be much more significant. We also found these things called concentric lamellae. This was Craig Keenan's work. These are lamellae around the calcified chondrocytes. We don't know what they are. We're not even sure that they're actually, there are more of them in osteoarthritis, but we certainly found them first in OA, and then, first in AKU in the mouse model, but now we find them also in normal mice, well, in non-AKU mice, aged mice. This again is a very subtle thing. It's really for the bone aficionados, but you can see this beautiful trabecular bone here, which, shown by the polarized light. Now, what I'm going to show you is these things here. These are totally new structures. These were identified by Alan Boyd using a new polarization technique. And what these are is they're things called Sharpie fibers, which are known in biology. They're when a tendon or a ligament inserts into bone. They've never been seen before in the marrow and in the trabecular bone. And what it tells us is that the marrow is actually loaded, and that basically there are mechanical connections between the marrow and trabecular bone. Using this technique, Alan was also able to show that so this is bone here. This is actually fibrous tissue in the marrow, and it's highly organized. We never realized that before. So again, a lesson from Ochronosis. Now, the most important lessons are yet to come, because we got the opportunity to get this hip from one of our patients. He's well known to us. He had lancinating pain in his right femur. His doctor obviously knew he had AKU. Not a lot of joint thinning, but they sent him for a joint replacement, and that is his joint. So it's actually, you can see, quite a good cover in your cartilage. The pigment is lower down. It's in the subchondral zone. So not a lot of loss of cartilage. It's a wonder why this person should have had lancinating pain. So we thought this is a great opportunity to look at this early stage of AKU by all techniques. So what we did is we did a micro CT, and that's not it, but this is it, almost as impressive. And you can see we identified these things which had never been identified before: high density mineralized protrusions. I'll show you how they form, but there. We actually had found them on MRI, but hadn't spotted them. But Nathan Jeffrey subsequently identified them. So the fact we can see them on MRI does give us some hope that these could be used as a marker of joint destruction. That's one there. Okay, how do they form? Well, this is a special technique that Alan developed to look at cartilage in backscattered SEM. It was actually, again, this was the inspiration for this was some work that Nathan had done in micro CT, where he used iodine to enhance the signal in soft tissues. And so what Alan did is he treated his samples with iodine, and so now you can actually see the cartilage in the backscattered EM. These are these high density mineralized protrusions that we found. If I press this button, hopefully this will get bigger. No, it won't, sorry. But I'm going to take you down. Can you see these little cracks here? So what we believe is that the aberrant loading in the AKU joint causes cracking of the subchondral plate. Then fluid leaks out through here and mineralizes. And because there's very low organic content in this, it's very mineral dense. It's actually as mineral dense as the enamel of your teeth. Actually, it's the highest mineral density of any material in the body. And of course, once you get these things in your cartilage, even if you've got quite good covering of cartilage, this is going to have a massive mechanical disruption. So we found this in AKU, and we thought initially it was AKU specific, but of course, then we found it in osteoarthritis. When we published that, we actually it did create some interest in the press. This isn't the best journal I've ever published in, but probably has one of the biggest impact factors. And you see this covering. Interestingly, the AR UK, the Arthritis UK people were asked to comment on this, and they said it was a wonderful example of how rare diseases can help the study of osteoarthritis. Having said that, we've never been able to convince them to give us any funding to pursue this. Now, Neil Thomas, who is a PhD student in the department, but he's also a lecturer in heart. I've put a picture of him here because not many of you might know Neil. He's not often in the WHD building. He's been looking in cadaveric joints, and he's identified these HDMPs in cadaveric joints, and subsequently he did a survey of the MRIs that were present in the osteoarthritis initiative. This is probably out of date now, but he's when he gave me this slide, he'd sampled 21 patients over 5 visits. 80% of patients have these things, and also the morphology change over time. Now, I won't show you the rest of his data in the interest of time, but I think this is really good evidence that these HDMPs are a major cause of joint destruction in human osteoarthritis. The way we think they form is, this is a cartoon of cartilage. Basically, when you get AKU, the loading becomes aberrant and cracks the subchondral plate. But loading also becomes aberrant with osteoarthritis in time because of changes in the cartilage. Then we get leakage of fluid, formation of the HDMPs, and that leads to massive damage of the articular cartilage and the joint, eventually leading to joint failure. Right, now, so far I've spoken mainly about anatomical things we've found, but our research is not restricted to that, and this is a very brief snapshot of some work that Brendan Norman's been doing, because he's been looking at the metabolomics of AKU. And what I want to sum up in this slide basically is that although AKU is a single gene defect, and so you would think that it would only affect the metabolism around that enzyme, in fact there's knock-on metabolisms, tyrosine metabolism as we would have expected, but there are also effects on purine metabolism on the TCA cycle. And during this study, Brendan also identified that homogentic acid can be conjugated to form sulfated form, glucuronide form, and acetylation form. And so these are the mechanisms that are used in basically when we're dealing with drugs, in drug detoxification. And I think most people didn't think that these mechanisms are actually, we call them phase 1 and phase 2 detoxification, are actually relevant to, if you like, normal or pathological metabolites. But in fact, of course, during evolution, these mechanisms have evolved to deal with metabolites that we would encounter in nature. So, very brief snapshot of Brendan's work. He's trying to get that published at present. It's been submitted for publication. Okay, now I'm going to go back now to the results of the SONIA 2 trial, because I told you before everything looked very positive, but we did spot some interesting results. And so here we've got adverse events. So whenever a clinical trial is done, people have to report if they've had any adverse events. It could be a nosebleed, headache, etc., etc. And here we have the untreated people. So these are the people who haven't received nitisinone, and here are the people with nitisinone. And I want to draw your attention to this, because if we look at all infections and infestations, there's 11 in the untreated group, 27 in the nitisinone-treated group. Urinary tract infections, 2 in the untreated group, double that in the nitisinone-treated group. And in fact, with respiratory infections, bronchitis 1 untreated, 5 in the nitisinone group, and in pneumonia, none in the untreated group, and 4 in the nitisinone group. Now, we're pretty sure that this is not a result of nitisinone treatment, because nitisinone is used in HT1. There's no reports of it having any effects on the immune system. Also, it's an incredibly specific inhibitor, and all of the effects we see in mice, for example, are due to its on-target effect on the HPD enzyme. So, what we wonder is if HGA or related molecules can influence the immune system. Now, there's 2 ways it could do this. One is it could boost the immune system. So I've drawn a little antibody here in this outline of a person, or it could actually kill microorganisms directly. Now we're presently testing these hypotheses, and just a little aside, this molecule, Hipposudoric acid, is actually, the chemists among you will spot that it's actually 2 HGA molecules stuck together. This is the constituent, one of the constituents of hippo sweat. It gives them the pink color, and it's thought of as possibly in a sunscreen, which it might well be, but also being an anti-bacterial agent on the hippo skin. And also HGA, which is our magic molecule, that's present in some honeys, and this strawberry honey's got a particularly high concentration of it, and this is folklore suggests that this honey is very good for infections. In fact, there are some academic studies on it as well. So how are we studying this? Well, Peter Wilson has actually shown that HGA kills E. coli. So you've got a plate of E. coli here, and you can see on this plate, when we add 10 millimolar HGA, there's much less growth. Now that's a big concentration of HGA. But if we go back to some of the results from Juliet's studies on the new mouse that George's team made, we can see that in urine, the concentration of HGA is much more than this. So in fact, the concentrations of HGA in urine are sufficient to completely arrest the growth of E. coli. And E. coli is the commonest cause of urinary tract infections. Now, the concentrations in plasma don't rise to the values that would kill bacteria. So we're not clear on how that might work. So could we use HGA as an antibiotic or an antiviral? And just to, I'm saying antiviral because if we go back and look at those figures, some of those infections appear to be viral infections, actually, of the respiratory tract. Well, no, because if we gave HGA, as I've shown you before, it's very rapidly broken down in the liver, and if it did survive breakdown in the liver, it would be very rapidly excreted. We actually tried once to give HGA to mice a long time ago, and you just can't increase the concentration. But what we could do is possibly, by transient knockdown, have a sort of a temporary AKU-like phase. So we would give subjects something to knock down this enzyme, their HGA would go up, and we might, it could be useful in fighting infections. So we've made some progress in this. So again, this is some work of Peter Wilson's work. This is just done in liver cells, but he's shown here. So this is the expression of the HGD gene in the controls, and this is a scrambled inhibitory RNA, siRNA, and here is a specific one. So we can knock down HGA in the liver cells. Can we do it in vivo? Well, we haven't tried with the HGD yet, but many years ago, we actually collaborated with an American biotech company who had the unfortunate name of ISIS then, actually, but they subsequently changed that to Ionis. And we tried to knock down another enzyme, HPD, in this pathway. And you can see, and this was done, Peter and Hazel Sutherland spent many days injecting these oligonucleotides into our mice. And basically, this is before we knew that nitisinone would work, and we were wondering if we might have to knock down HPD by other techniques. And so you can see this is the PBS, the control ASO, and this is the knockdown of HPD. So you can see we clearly can knock it down, can knock enzymes in this pathway down in vivo. Right, I think I'm coming to the end. These are my conclusions. Nitisinone is an effective therapy for AKU. Studying rare diseases teaches us about more common disorders. One, for the anatomist, it's still possible to find new anatomical structures. We've found 4, at least. And also, AKU appears to be in an anti-infective state. Right, just remains to me to thank my many collaborators. This is our Zoom meetings. You can see the team here, and that's we're flying our flag there, and also this is a list of all of the people who have collaborated with us over the years. Obviously, Ranga has been the key person here, but I must say that since George has come, he's been a fantastic collaborator and developed a new mouse for us. You can see all of the team here. Some of them have moved on, and of course, Alan Boyd in London. Funders, the AKU Society, the Big Lottery, the National Alkaptonuria Centre, a little bit from MRC, and a fantastic grant from the EU. Thank you, that's it.
Great, thank you very much, Jim. That's an enormous amount of work, obviously, involved in that. There are a couple of questions that have been put in, but I'm sure people will carry on adding questions now. So Yalin asks about the SOBA studies that you submitted for the, sorry, has SOBI submitted the EMA application, or is it still planned to be submitted? I
think it's gone in. Or certainly all the paperwork's ready. It's either submitted or about to be submitted, yeah.
Yalin, did you have a particular question about that then? Yalin, do you want to ask your question any further on that?
Sorry, sir. Just now, yeah, I just muted myself. Yeah, just want to know, yeah, the progress in this, because this is related to our impact.
Yeah.
Right.
So yeah, I think it's actually gone in, and also the paper has been reviewed. It's got favourable reviews, and we've sent that. Ranga's sent that back in for revision. We sent that back in on Monday, so that hopefully will come out in Lancet Endocrinology and Diabetes.
Yeah, that's excellent. Yeah.
And so, Jim, on your SONIA 2 study, how long were your patients on the nitisinone for?
4 years, yeah.
4 years, okay.
Mm-hmm. Yeah, and it's a slow progressing disease, and so we needed to do that. It was a challenge, and we were delighted with the results. When we went to the EMA before the trial, and they said we needed to show not evidence. We need to show conclusively that it reduced HGA and kept it down. We knew that was going to work. And they said they only asked us for trends towards clinical benefit, but we actually got some highly statistical changes. And like with the eye changes, I was really pleased that they came out significant, because I just thought that we hadn't, that in hindsight we could have had more categories and designed them.
I think that's one of the problems, though, isn't it, with these slowly developing diseases, is just how long the experiments, the clinical trials have to be to get a result, which can be very inhibiting. So Helen asks, does nitisinone just prevent pigmentation, or does the actual sort of breakdown stop? Does that change the pathology of the disease?
That's a really good question. So initially, I didn't believe that you could get reversal of pigmentation. And if you've ever handled the pigment, it's got the consistency of sort of tissue culture plastic. It's quite hard stuff. And and it's solid. I can't think of how anything would break it down. But actually, we've just submitted a paper showing reversal on treatment of nitisinone. Now, it's reversal in the scleral pigmentation, or certainly the eye pigmentation. We get some conjunctival pigmentation first, but also some in the ears. So it does look like there is reversal. Now, in the mouse, we didn't see any reversal, and that's because, maybe because that pigment is buried deep in the calcified cartilage, and it's not accessible to any cells or enzymes that might cause reversal. But probably the early pigmentation we see in the eyes and ears of young people is reversible, yeah. And we don't know the mechanism.
And Liz asks, could the nitisinone treated group be taking less other medications, for example, NSAIDs or other painkillers? Yeah,
that's a very good question again. So Brendan is doing metabolomics on these patients, and so he found one peak that was coming up in that correlated with severity in the spine, and when he identified it, it was ibuprofen. So so when the people are on this drug, they're given dietary advice, but they're not put on a strict diet, and they can take any other medicines that they would normally take. And so it's highly likely that the people who have got more severe disease are taking a lot more NSAIDs. And also we think that there's another thing which we don't understand, but when people initially go on nitisinone, although there's no immediate change in ochronosis, they actually do seem to say they've got less pain. So I think people on nitisinone are probably taking less NSAIDs. So it's a complicated system, and it could also, of course, be affecting those infection figures. Another thing is, these people, once they're on nitisinone, they actually get up and walk around a lot more. They go out more, so they might actually be coming into more contact with opportunities to get infections. But nevertheless, HGA has got these remarkable qualities.
And Rob says aging leads to increased bone adipocytes. So do you think that the novel trabecular bone structures increase with aging? And do you think that this affects bone function?
So we haven't done a systematic study on this, Rob. What we looked in AKU first, and the next group of patients we looked at, group of donors we looked in was cadavers in heart, and by the nature of bequeathal, they were an older group. Adam Taylor's pursuing this in Lancaster. He's got a PhD student doing this, and they're actually taking they're actually isolating the adipocytes and looking at whether they're brown, beige, or white adipocytes, etc. Also, Cliff Rosen, who's very well known in the bone field, he's one of the editors of New England Journal of Medicine. I know he's working on this now. He was actually invited to do the address at OSCE last year. So I think there's a massive. It's going to be a big area of research, and of course, Rob mentioned the Wnt pathway when he did his talk a couple of weeks ago. That affects adipocyte differentiation. So we've only just scratched the surface with it, and we probably won't look at it a lot further because we've got just other things to look at.
Yeah. And what about the collagen? So does collagen type 4 also attract the HGA, or is it just the fibrillar collagens?
It seems to be the fibrillar collagens, and again, we don't really completely understand that. So if you look at a really good place to look at early ochronosis is on the boundaries. So perichondrium, where you've got type 2 and type 1 in close juxtaposition, that seems to pigment quite early. So if you looked at the tracheal cartilages, we can't see any evidence in type 4, the sheet-like collagens, but we can't discount that. One interesting thing was that one of our patients had a mediastinal mass and went for surgery, and so in this mass there was a lot of newly synthesized collagen, and I think with this rapid fibrosis collagen, it's not well organized. There's less proteoglycans protecting it, and so and they had pigmentation of that the mass that was excised. We could show that was pigmented. So basically, well-formed good collagen with intact proteoglycans is resistant. If you have any problem with the collagen, if it's rapidly secreted, or if it's partially degraded, or if it's mechanically damaged, then it pigments.
Great. Any other questions, anybody? One last one coming in. Any idea what fibrous material in the marrow is made of?
Yeah, it's type 1 collagen mainly, but there is some type 3 in there and type 6. I think that highly ordered stuff that we've seen is almost certainly going to be type 1, and the sharpie fibers that are poking into the trabecular bone are also almost certainly to be type 1, but that needs to be established. Great.
Well, thank you very much, Jim. Really, really good to see it all put together. And these seminars, I think we're learning so much about all these different things that are going on in the Institute.
Yeah.
So thank you very much, everybody.
Pleasure.
And hopefully see you all next week.
Okay. Bye.
Bye.